Because most clinicians find acid-base to be difficult, if not impenetrable, they tend to use a series of rules of thumb to help them work out various acid-base conundrums. The most commonly used one, of course, is the very simple anion gap. But for respiratory abnormalities, and indeed to a certain degree metabolic abnormalities, other rules of thumb look at the relationship between carbon dioxide and bicarbonate. In general, in most of the textbooks and in most of the online resources, those rules of thumb are reported in millimeters of mercury. But if you live in the part of the world where your blood gas machine spews out data in kilopascals, those rules of thumb are very difficult to apply. So what I'm going to do in this tutorial is try and reframe those rules using kilopascals, and I hope you find it useful. kPa rules, part 2, acid-base. For the majority of clinicians who look at blood gases, there has been minimal evolution of the understanding of acid-base balance since the mid-1960s, and the minimalist approach based around bicarbonate and pH, and indeed the anion gap, has endured and been handed down from generation to generation. Many of the rules of thumb are derived based on PaCO2 in millimeters of mercury. The purpose of this tutorial is to provide you with the same rules in kilopascals. I will point out two things from the outset. The smaller numbers in kilopascals are more awkward to work with, meaning that these rules are harder to recall from memory. Secondly, as the rules are derived from very small cohorts of patients, not populations, and rounding up is necessary to get them to work, the results are only approximations. They are really useful nonetheless. Acid-base balance is about the pH of blood, and arterial blood pH is maintained at around 7.4, or a hydrogen ion activity level of 40 nanomoles per litre. An acute rise in the hydrogen ion activity results in acidosis, that's a pH of lower than 7.35, and an acute fall in the hydrogen ion activity, or a rise in the pH, is known as alkalosis. If the primary cause of an acid-base abnormality is a change in the PaCO2, we call this respiratory acidosis or alkalosis. If it's acute respiratory acidosis. If it's acute respiratory alkalosis. But you can have chronic respiratory acidosis in, for example, COPD. You can also see chronic respiratory alkalosis in, for example, cirrhosis. Metabolic abnormalities are based on a problem in the relative concentrations or charge carried by electrolytes. That's cations, positively charged electrolytes versus anions. And if there is an imbalance between the two, we call this metabolic acidosis or alkalosis. For example, in metabolic acidosis, there is a surplus of strong anions, such as chloride, lactate, ketones, and metabolic junk products that accumulate during acute kidney injury. In metabolic alkalosis, there is a deficiency of water, we call that a contraction alkalosis, and or a surplus of sodium over chloride. So hypernatremia, hypochloremia, or a relative difference that increases, or low albumin, hypoalbuminemia. And hypoalbuminemia is the commonest cause of metabolic alkalosis in critical care. The strong ion difference is the major mechanism behind metabolic acid-base balance. The cations minus the anions equals 0. So the sodium plus the potassium minus the chloride plus the lactate plus the ketones plus the metabolic junk products equals the charge that's carried on all the other anions, bicarbonate, phosphate, and albumin. And this is analogous in some ways to the anion gap. If the strong ion difference is reduced, there are more anions present than cations, and that leads to acidosis. If there is an increase in the strong ion difference, there are more cations present than anions, and that results in alkalosis. Finally, in this introduction, if you're converting from millimeters of mercury to kilopascals, remember this. 1 kilopascal equals 7.5 millimeters of mercury. 10 millimeters of mercury equals 1.3 recurring kilopascals. Let's start now with respiratory acidosis. You're in the operating room and Adam is on the table. He's a 24-year-old male, ASA physical status 1, and he's having elective surgery, and you are, for example, the anesthesiologist. Following induction of anesthesia and intubation, you forget to turn on the ventilator. 10 minutes later, the desaturation alarm goes off. If immediately after restarting ventilation you were to measure the pH, the PaCO2 and the end-tidal CO2, what would the measurements be? Can you figure this out without knowing any other information? Well, let's start with something that should be fairly obvious. Carbon dioxide is an acid, and as the partial pressure of carbon dioxide rises in the blood, so too does the hydrogen ion activity, and the pH of blood falls predictably. And for blood, you can also see extracellular fluid because that's what happens. It diffuses across the extracellular space. There is a correlation between the hydrogen ion activity and the pH. And this is my first rule of thumb. For every 1 nanomole per liter increase in the hydrogen ion activity, there is a 0.01 fall in the pH. So, if the hydrogen ion activity rises to 50 nanomoles per liter, what is the pH? Normal hydrogen ion activity is 40 nanomoles per liter and the normal pH is 7.4. These directly correlate. In this situation, the hydrogen ion activity has increased to 50 nanomoles per liter. That's a change in hydrogen ions by 10 nanomoles per liter. The pH is 7.4 minus the change in hydrogen ions multiplied by 0.1, and that answer is 7.3. When you look up changes in pH and bicarbonate associated with acute hypercarbia, you will be directed to this paper that was published by the Boston group in the New England Journal in 1965, where 7 healthy volunteers were exposed to increasing quantities of inhaled carbon dioxide and the pH and bicarbonate levels were measured, and these are the results. Of course, in the scenario that I've given you, we were looking at apnea, not breathing CO2. So there's lots of data in the anesthesia literature, a lot of it produced by my colleague Craig Lyons over the last number of years, that have looked at apnea and the changes in oxygen and the partial pressure of CO2. And this is the classic picture that happens when a patient becomes apneic. The CO2 rises quite a lot in the first minute and then it rises slowly thereafter. And there is a pretty easy calculation that you can use. In apnea, the PaCO2 rises by about 1.5 kilopascals in the first minute and then by about 0.5 kilopascals per minute thereafter. Remember this, 1.5 in the first minute, 0.5 per minute thereafter. So what about Adam? So after 10 minutes, the PaCO2 will increase from 5.3 kilopascals to 1 time 1.5, that's the first minute, and 9 times 0.5 kilopascals, and that works out at 6 kilopascals. And to this you're going to add 5.1, so that after 10 minutes, Adam's partial pressure of CO2 in his blood may well be 11.1 kilopascals, more than twice what we would have expected at the very beginning of all this. And because there is only a small difference between the end-tidal CO2 and the arterial CO2, assuming that the tidal volume is adequate and there's not a lot of dead space ventilation, the end-tidal will be around 11 kilopascals. Remember, that might not be apparent in the first 2 or 3 breaths. So we know that Adam's PaCO2 is approximately 11 kilopascals. From this, how can we figure out what his pH is and what his bicarbonate level is? We need another rule of thumb. A rise in the PaCO2 results in a predictable rise in the hydrogen ion activity and a fall in the pH. For every 1 kilopascal increase in the partial pressure of CO2, the pH falls by 0.6. So let's work this out for Adam. Adam has been apneic for 10 minutes and he has a PaCO2 of 11.1 kilopascals. That is a rise in his PaCO2 by 6 kilopascals. Now we know that the pH falls by 0.06 for every 1 kilopascal increase in the PaCO2. So 6 times 0.06 equals 0.36. So the pH falls by 0.36 from 7.4 minus 0.36 to 7.04. To calculate the hydrogen ion activity, we divide 0.36 by 0.01, and that gives us a rise in the hydrogen activity by 36 nanomoles per litre to 76 nanomoles per litre. That's a pretty impressive fall in pH and increase in hydrogen ion activity. But because of the way that carbon dioxide is handled by the body, by just giving the patient a slightly raised minute ventilation for a couple of minutes, this all resolves very, very quickly. We need to move on now to talk about bicarbonate. Carbon dioxide and bicarbonate are the same thing. As PaCO2 rises, the bicarbonate rises, and vice versa. It's important to remember that the manufacture of bicarbonate in red cells occurs relatively slowly, so that if a patient becomes acutely hypercapnic, such as Adam, one wouldn't expect a rise in the bicarbonate over the first 10, 12, 15, 20 minutes. In fact, our experience is that the bicarbonate might actually fall in that situation. But if someone has been hypercarbic for many hours, the bicarbonate will actually rise. Let's look at a scenario. You're called to the emergency room to see Pamela, who is 47 years old. She presents with dyspnea and rapid shallow breathing, and she's been in respiratory distress for 2 days. On admission, her blood gas reveals a PaCO2 of 9.1 kilopascals. What is her likely bicarbonate? Well, it's tricky to map the bicarbonate to the PaCO2, and traditional approaches have used rules of thumb from the 1960s that equate the rise in the PaCO2 to the rise in the bicarbonate. This is traditionally referred to as acute versus chronic hypercarbia, but the terminology is problematic. When does the bicarbonate start to rise, and when does acute turn to chronic? Firstly, I'll just give you the traditional approach. In acute respiratory acidosis, a rise in the PaCO2 of 10 millimeters of mercury results in a rise in the bicarbonate by 1 millimole or 1 milliequivalent per litre, and there is a calculatable change in the pH from that I've already covered. In chronic respiratory acidosis, a rise in the PaCO2 by 10 millimeters of mercury results in a rise in the bicarbonate of 3 millimoles per litre. Just to explain what this is all about. In our normal situation, we have a PaCO2 of 5.3 kilopascals or 14 millimeters of mercury. There is a steady state relationship between the production of carbon dioxide and the production of bicarbonate, and the bicarbonate level is 24 millimoles per litre. If over several hours, maybe a day or two, the carbon dioxide level rises, then the bicarbonate level will, by definition, also rise because bicarbonate is a byproduct of carbon dioxide. So the bicarbonate level will rise, but it arises slowly. But if that process goes on longer, maybe days to weeks, and we see this in our patients who are mechanically ventilated in the ICU, then the CO2 remains high and the bicarbonate rises higher still because the total body content of carbon dioxide is now much, much higher, and that was represented by this high bicarbonate level. Where we run into a little bit of trouble is trying to convert these numbers in millimeters of mercury to kilopascals, and there is a discorrelation between the rules that are presented in the literature on the American side of the Atlantic that uses millimeters of mercury versus on the European side of the Atlantic that uses kilopascals. This is quite widely referenced, this particular paper in Thorax in 2008, where alternative rules of thumb that don't quite correlate with the US versions are presented. However, I do think that the approach of acute respiratory acidosis works reasonably well, and the rule of thumb that I'm going to suggest is that an increase in the PaCO2 in acute respiratory acidosis of 1 kilopascal usually results in a rise in the bicarbonate of 1 millimole per litre. So if we look at Pamela, who is 47 with community-acquired pneumonia and rapid shallow breathing, if her PaCO2 rises from 5.1 to 9.1, then the increase in the bicarbonate is 4 millimoles per litre, and therefore her bicarbonate will be 28 millimoles per litre. Of course, in the case of Adam, who has a not dissimilar rise in his PaCO2, we wouldn't expect his bicarbonate to rise over the 10 or so minutes that he was apneic in the operating room. So the rule is, in acute hypercarbia, the bicarbonate rises by 1 millimole per litre for every 1 kilopascal increase in the PaCO2, and the pH falls by 0.006. Let's look at another clinical scenario. We're in the preoperative clinic and you see Philip, who is 72 years old. And he presents with a history of smoking and probable COPD, and there's a plan to do surgery on him. His labs include a hemoglobin of 16 grams per deciliter, which means he's polycythemic. He's got a sodium of 140 millimoles per litre. His potassium is 4 and his chloride is 90. His total CO2 on his labs is 36 millimoles per litre. Now the total CO2 is essentially the bicarbonate. Now you're going to take this patient to the operating room and you're going to mechanically ventilate him during surgery, and it's really important that if a patient is chronically hypercarbic that you don't blow the CO2 down to normal levels, or else you can cause intracranial vasoconstriction and a reduction in the intracerebral blood flow. So it is worth figuring out in this case, what is Philip's resting PaCO2? Now, a lot of our understanding of this, and I've mentioned this earlier on, comes from a series of papers done by Brackett, Schwartz and colleagues back in the 1960s. And there is a paper in 2008 that looks at this and suggests an alternative approach, alternative numbers. And I think it's just worth mentioning that I have looked at the changes in the pH of blood versus the different rules whereby perhaps for every 1 kilopascal increase in CO2, there may be 2 millimoles per litre increase in bicarbonate, 2.5, 3, or 4. And if you look at this particular table, you can see that 2.5 is probably the most accurate reflection of the traditional approach. But I must say that when I have applied the traditional approach in my clinical practice, I think it oversells the CO2 and undersells the bicarbonate, meaning that if you're to go by the bicarbonate that's measured, often that will show a CO2 that is way higher than you would expect for the patient. So I think the +3 rule is a better rule. And that is what I'm going to suggest. This is not based on compelling evidence. This is not based on research that I have done. It's based on my own clinical experience, but I think this works the best, and I'm going to recommend this. So in chronic respiratory acidosis of hypercarbia, an increase in the PaCO2 by 1 kilopascal chronically results in an increase in the bicarbonate by 3 millimoles per litre. So if we look at Philip, our smoker at the pre-op clinic with a bicarbonate of 36, his bicarbonate is 12 millimoles per litre higher than one would normally expect. And using the rule of thumb, a 3 millimole increase in bicarbonate for every 1 kilopascal increase in PaCO2 in chronic hypercarbia, that's a 4 kilopascal increase from baseline. So the PaCO2 is increased up to approximately 9.1 kilopascals. And I make a big point of approximately here. There is a range, but it's somewhere up there between 8.5 and 9.5. So the rule is, in chronic hypercarbia, the bicarbonate rises by 3 millimoles per litre for every 1 kilopascal increase in the PaCO2, and importantly, the chloride falls by an equivalent amount. The strong ion difference increases. Just to summarize that at the end of this part of the tutorial, in acute hypercarbia, for every 1 kilopascal increase in the PaCO2, the bicarbonate rises by approximately 1 millimole per litre. In chronic hypercarbia, for every 1 kilopascal increase in PaCO2, the bicarbonate rises by approximately 3 millimoles per litre. Now let's move on and look at respiratory alkalosis. You're in the emergency room and you're called to see Carol, who's 48, and she's hyperventilating. Now she seems to be having a panic attack and becomes dizzy and loses consciousness, and you check a blood gas. And on the blood gas, her PaCO2 is 3.7 kilopascals. This can be one of two things. This can be acute respiratory alkalosis associated with a panic attack, or maybe Carol is really sick and she has acute metabolic acidosis, in which case the bicarbonate will be very different. So if you think it's acute respiratory alkalosis, what is Carroll's likely bicarbonate? Well, the rule of thumb for this is that the change in the bicarbonate in acute respiratory alkalosis is -2 from resting for every 1 kilopascal change in the CO2. So for the every time the CO2 drops by 1 kilopascal, the bicarbonate drops by 2. It's caused by pain, agitation, anxiety, brain injury, and that's the calculation. So in this case, we have a PaCO2 of 3.7, and so the way to calculate that out is 2 times 5.3 minus 3.7, and that equals 3, and 24 minus 3 is 21. That's really important because in acute metabolic acidosis, as we will see later in this tutorial, the bicarbonate is much lower. Again, the rule of thumb, in acute respiratory alkalosis, both the PaCO2 and the bicarbonate fall in a predictable manner, and there is no change in the strong ion difference. The change in the bicarbonate is twice the change in the PaCO2 in kilopascals. Let's move on to metabolic acidosis. You're in the emergency room and you're called to see Helen, who's 39, and she's also hyperventilating. Now, Helen has a background of type 1 diabetes, and you check a blood gas, and her pH is 7.19, PaCO2 is 4.1, the bicarbonate is 12 millimoles per litre, and the base excess is a base deficit of -12. Metabolic acidosis is caused by a reduction in the strong ion difference. The body compensates for metabolic acidosis by increasing alveolar ventilation, so the patient gets a compensatory respiratory alkalosis. There is a mathematical relationship between the fall in the bicarbonate and the fall in the PaCO2 in acute metabolic acidosis. If the fall in the PaCO2 is inadequate, there is either a concomitant respiratory problem or the patient is running out of reserve and they're in trouble. The rule of thumb for this was derived by Winters in 1967 on a group of children in which observations were made looking at the change in the PaCO2 versus the change in the bicarbonate or base deficit. The rule is that for every 1 millimole per litre decrease in the base deficit, the PaCO2 falls by 0.13 kilopascals. There is no easier way to do this. Now let's look at Helen. And I recommend that you do these calculations yourself. The change in the CO2 in kilopascals for Helen, who has a metabolic acidosis, should be the base deficit multiplied by 0.13. Now we know that Helen's actual PaCO2 is 4.1 kilopascals. So let's work out the predicted PaCO2, and that should be the normal PaCO2 5.1 minus the base deficit 12 multiplied by 0.13. Pause this and work this out yourself. The number that you will come up with is 3.7. And 3.7 is substantially lower than 4.1. It might look like a little number, but it's actually a big number because kilopascals are little big numbers. And in this case, it means that Helen's respiratory compensation is inadequate. She's in a lot of trouble. In this case, Helen likely has diabetic ketoacidosis, so you should calculate out the anion gap on the labs, check her blood ketones, her beta-hydroxybutyrate, check her plasma lactate levels, and then look for hyperchloremia. Now this will appear as a high chloride on her labs because it's very hard to figure this out when you have a combined widened and narrowed anion gap at the same time. That's why I sort of disrespect the anion gap in this situation because there is so much going on. But a chloride of over 105 is evidence of hyperchloremia, assuming that the sodium is lower than 145. You should also look for elevated urea and creatinine. In this scenario, all of the causes of metabolic acidosis are addressed. Ketoacidosis, lactic acidosis, hyperchloremic acidosis, and so-called renal acidosis that occurs due to the accumulation of metabolic junk products. The rule here is that in metabolic acidosis, the PaCO2 should fall proportionately to the bicarbonate and the base deficit. The fall in the bicarbonate usually mirrors the fall in the base deficit. So if bicarbonate falls by 12, the base deficit is minus 12. Not always the case, but usually in acute metabolic acidosis. For every 1 millimole per liter fall in the bicarbonate or base deficit, the PaCO2 should fall by 0.13 kilopascals. Now let's look at metabolic alkalosis. You're in the ICU and you have Tomas. He's 52 and he's been in the ICU for 2 weeks. He was admitted with community-acquired pneumonia, congestive heart failure and septic shock, and now he's extubated following antibiotics, vasopressors and diuretics. On his blood gas, his pH is 7.52, that's an alkalosis. His bicarbonate is high, 32 millimoles per liter, and his base excess is +8. In this situation, it looks like Tomas has a primary metabolic alkalosis. So what is Tomas's likely PaCO2? The body compensates for metabolic alkalosis by reducing alveolar ventilation, so you get a compensatory respiratory acidosis. The traditional rule for this is the PaCO2 in millimeters of mercury in metabolic alkalosis is 40 millimeters of mercury plus 0.7 times the current bicarbonate plus the predicted normal bicarbonate of 24. Now in kilopascals, we can look at it like this. For every 1 millimole per liter increase in the base excess or the bicarbonate concentration, the PaCO2 will increase by 0.13 kilopascals from 5.3. This is obviously not that easy to do. So let's look at Tomas. Now we know that his bicarbonate is 34 millimoles per liter and his base excess is +10, and that's an increase in 10. The PaCO2 should be 5.3 plus 0.13 times 10, and that equals 6.6 kilopascals, the exact same number as you will get if you use the traditional approach and multiply the kilopascals by 7.5. So the rule is, in metabolic alkalosis, the PaCO2 should rise proportionately to the bicarbonate and the base excess. For every 1 millimole per liter rise in the bicarbonate or base excess, the PaCO2 rises by 0.13 kilopascals. I want to briefly look at metabolic alkalosis in the ICU. By definition, there is an anion deficit. There is a surplus of cations over anions, and electrical neutrality is maintained by retaining bicarbonate both renally and as a consequence of hypoventilation. The most common cause of metabolic alkalosis in intensive care is hypoalbuminemia. The impact of low albumin on the base excess is calculated as 0.25 times the normal albumin of 42 grams per liter minus the measured albumin in grams per liter. So if Tomas's albumin is 22 grams per liter, his base excess for hypoalbuminemia is 42 normal minus his 22 divided by 4, and that will give you the charge carried by albumin. And in this case, there is a deficit in charge carried by albumin, so the base excess is +5. Remembering that albumin is a weak anion. The other causes of metabolic alkalosis in the ICU relate to strong ions. In particular, when the sodium to chloride ratio increases above 1.35 to 1. Usually what that means is that chloride has fallen below 100 millimoles per liter. And you see this in hypochloremia associated with vomiting, but sometimes also diarrhea. There can also be a widening of the sodium to chloride ratio due to hypernatremia. So the chloride might be normal, but the sodium goes up. And this happens due to diuretics or diuresis, such as what we see with acute kidney injury or diabetes insipidus, or the administration, of course, of various different diuretic agents. This results in what some people call a contraction alkalosis due to a so-called free water deficit. The last cause of metabolic alkalosis in this setting is the administration of sodium intravenously, usually without chloride. This is the administration of sodium bicarbonate solutions, such as is commonly given, for example, in patients who have rhabdomyolysis, the administration of sodium citrate, which we give a lot of in the guise of blood transfusions. Remember that blood is anticoagulated with sodium citrate, and then with sodium gluconate or acetate, depending on how it's given, for example, in total parenteral nutrition. Let's review this tutorial. In this tutorial, I discussed the use of carbon dioxide in kilopascals as part of ways of figuring out what's going on in acid-base balance, the so-called acid-base balance rules. Now, these are not hard and fast rules, they're approximations, and I'm not claiming that these are highly accurate, but they have been used for the last 60 years, and most doctors use some form of them in their clinical practice. I started with acute respiratory acidosis, where there was a small increase in the bicarbonate. Chronic respiratory acidosis, there's a large increase in the bicarbonate. In acute metabolic acidosis, the bicarbonate falls, and it predictably falls in relation to the strong ion difference. Finally, I discussed metabolic alkalosis. I didn't distinguish between acute and chronic because in our practice, acute metabolic alkalosis is almost always caused by the iatrogenic administration of fluids such as sodium bicarbonate. We commonly see, almost universally see, metabolic alkalosis in our critically ill patients who have a combination usually of hypoalbuminemia and free water deficit or hypernatremia as a consequence of diuresis. Thank you. So that was the kPa rules in acid base. I hope you found it useful. If you enjoy these tutorials, subscribe to my YouTube channel, give me likes, give me a couple of comments, they're always helpful, and encourage some of your pals or your friends or your colleagues to visit the channel to find out more information. I also have a blog, ccmtutorials.org, that covers everything in this channel plus other material.